Good morning and afternoon. My name is Tracy Cook, and I'm with Sachs Healthcare Communications. Before I introduce our moderator and speaker, on behalf of Medtronic and Sachs Communications, we would like to thank all the frontline workers in our audience for your commitment and passion in helping us all through this very difficult time. We are truly indebted to you. I would like to show our audience today how to send questions, which our speaker will answer as many as possible at the end of the webinar. Our moderator is Lisa Wilkie. Lisa is a registered nurse with an extensive clinical background in gastronomy and research. She began her nursing career at Indiana University. Lisa is currently with Medtronic Medical Affairs Group, where she provides medical and clinical input and facilitates insightful decision making. Lisa, welcome.
Good morning and afternoon, everyone, and thank you, Tracy, for that very kind introduction. The title of today's webinar is Crohn's Disease, Diagnosis, Treatment, and Monitoring. Speaking today on this very timely topic is a leading expert in the field, Dr. Bensi Abraham. Dr. Abraham is the Distinguished Professor and Director of the Fondren Inflammatory Bowel Disease Program at the Underwood Digestive Diseases Center of Houston Methodist Hospital, where she also is the Program Director for the Gastroenterology Fellowship Program. Her particular interest in inflammatory bowel disease includes the transition of adolescent IBD patients from pediatric to adult care, as well as women's issues in pregnancy and IBD. She served as president of the Texas Gulf Coast Gastroenterology Society and is a fellow of American College of Gastroenterology, American Gastroenterology Association, and Crohn's Colitis Foundation. Dr. Abraham's disclosures include research and grant support from Janssen, AbbVie, UCB, Takeda, and Celgene. She also receives consulting and speakers fees from AbbVie, Janssen, UCB, Takeda, Pfizer, Medtronic, and Samsung. Continuing education for physicians. This program has been awarded 1 AMA PRA Category 1 credit, and for nurses, this program has been awarded 1 contact hour. A link to obtain CE credits will be available at the conclusion of the webinar, and support for this educational activity has been provided by Medtronic. Now, I would like to turn the presentation over to Dr. Abraham.
Thank you, Lisa. I'm glad to be here today to talk to you all about Crohn's disease, diagnosis, treatment, and monitoring. So today's objectives includes defining the clinical and endoscopic features of Crohn's and list the steps that you need to diagnose and stage Crohn's disease and identify predictors of severe disease and methods to evaluate the disease status in these patients. So we all are aware that Crohn's disease can affect anywhere in the GI tract, from the mouth all the way to the anus. But majority of our patients will have right-sided disease, the right colon to the end of the small intestine. But there are a subset of patients who may have only small bowel disease, which may become undetected based on regular endoscopic evaluation by upper regular colonoscopy. So we need other modalities of evaluating these patients with their specific anatomic distribution. Now, we all know that there are specific features that we need to be concerned about Crohn's disease compared to another type of inflammatory bowel disease, such as ulcerative colitis. Now, ulcerative colitis only affects the colon, but Crohn's can affect anywhere in the GI tract, but that includes the colon, the small bowel. But some interesting features of Crohn's includes patients developing strictures or fistulations or perianal disease and granulomas on biopsies. Typically, you tend to have skipped lesions or focal lesions rather than having continuous lesions. So these are some of these findings that are specific for Crohn's disease. Now, when diagnosing a patient, it's very important to have an accurate colonoscopy. As a gastroenterologist and as a teacher to fellows, I always tell them that first colonoscopy is the most important. Use this to stage the patient's disease activity, assess their ileum and their entire colon, assess their ileocecal valve, because accurate endoscopic reports important, and taking biopsies are also important because the pathologist can interpret areas of histological activity, even in areas that visually may look normal to you as an endoscopist, but may have activity on under the microscope. So it's important to know how diffuse the disease is. Now, there are multiple types of appearances on endoscopy of Crohn's. You can see severe deep ulcerations in some of these pictures in the bottom, to small aphthous ulcers in that second picture from the left, and even anal fissures can be seen as well. So you can see a broad variety of appearances. It's important to know severity and look at these, and when you're taking biopsies as well, in the most severely diseased areas. Now, endoscopically, we can use colonoscopy, we can use capsule endoscopy, and upper endoscopy, as we typically call as EGDs, to evaluate Crohn's, because again, it can occur anywhere in the GI tract. Now, importance of evaluating these patients is to diagnose the patients early, and we know in the clinical practice is if we can diagnose these patients early on, we want to treat them early before complications such as strictures and fistulas occur, because that will put them at higher risk of getting surgery. What we know is that patients who have Crohn's disease, about 80% of them will undergo at least one surgery during their lifetime. And so it's important to diagnose these patients early and use this window of opportunity. And what I mean by that is getting our patients treated with medical therapy early on after diagnosis, where you have the highest potential for response to therapy, compared to waiting later on throughout the years when they've developed complications and structural damage, where they have a low chance of responding to medical therapy, and they'll having to undergo multiple surgeries. Now, how do you predict severe disease? How will you know that some patients will end up getting surgery compared to those that may not? Well, there are several specific factors for Crohn's that we can evaluate from a clinical aspect and lab work as well. So, age at onset, patients younger than young age, less than 40, having ileal or ileocolonic or upper GI disease, having fistulas and stenosis, especially upon diagnosis, having small bowel disease location, severity, perianal lesions, needing steroids. So a lot of these factors have been found to predict more severe disease, some genetic markers and serological markers as well. So you can see a long list here. And if a patient has multiple of these factors, you know you need to be very aggressive in treating these patients. Now, our goals of treatment is to induce and maintain our clinical remission, so meaning that the patients feel well, but not only that, we want to get them to mucosal healing, and I'll explain more about it in the future slides. Also, with any therapy that we use, we want to make sure that you have an acceptable risk to benefit ratio, and of course, to have our patients a great quality of life. They can lead a normal life without thinking of their disease contributing to symptoms all day. Now, how do we decide on what is appropriate treatment? Our national guideline, the AGA, is actually set up a care pathways and management tool for Crohn's patient. So first and foremost, what we need to do is assess inflammatory status, look at labs, symptoms, inflammatory markers, endoscopy, imaging is needed. And then you look at assessing comorbidities and disease and therapy-related complications. Do they have other medical problems? How severe their disease? Do they have prior surgery? Do they have infections? What's going on from a mechanical standpoint? Do they have strictures? And once you know that, then you also need to identify if the patient is low risk or high risk. We talked about some of the severe prognostic indicators for a severe disease activity. So if they're higher risk, like such as the things that are listed here, then you need to be more aggressive and treating them early on aggressively in their disease compared to those with lower risk factors. Now, this seems like a pretty complicated treatment algorithm for Crohn's. However, one thing to keep in mind is if you have someone with mild disease, you may be able to get away with milder medicine such as budesonide. So I was presenting on those patients that had mild disease to it's okay to go ahead and give them budesonide or immunomodulator therapy. However, those patients that have moderate or severe disease based on clinical symptoms, endoscopic or imaging or capsule endoscopic findings, we need to be a bit more aggressive in them. Typically, they need biologic therapy for Crohn's disease management. You can induce remission with prednisone if they need to. I try to avoid it if it's all possible. However, once you get them to maintenance therapy, you should be able to withdraw the prednisone. If not, then you need to make sure that you optimize their biologic dosing, either by adding an immunomodulator with the anti-TNF therapies, or adjust dosing as needed for your other biologic therapies. If they don't respond, then you need to change their mechanism of action to a different biologic therapy. And in those patients that have severe disease and not responding despite optimization of all medical therapy, you may need to also consider surgery for them as well. So what are some indications for surgery in Crohn's disease patients? Obviously, we know that it's a medical emergency if a patient has a perforation, and so those patients would require surgery. A severe hemorrhage that's not able to be handled by medical therapy, and the patient needs significant number of packed RBC transfusions would be an indication for surgery. Of course, patients with fibrotic obstructing strictures that's preventing them from eating and they're losing weight, unable to get things to go through, then they will need surgery. Of course, cancer would be an unfortunate indication for surgery. However, that is something that can occur with longstanding disease. Of course, patients that have complex fistulas and abscess and perianal complications will need to be seen by a colorectal surgeon and evaluated for surgery as well. In the pediatric realm of Crohn's, having delayed growth could be an indication, especially if you've exhausted medical therapy for that patient. They may need to start fresh with surgical management of Crohn's and then restart medical therapy afterwards. At any time with optimization of medical therapy, the patient continues to have a poor quality of life, you should also consider surgery for these patients. Now, we talked about the diagnosis, evaluation, and kind of potential complications of the disease and how to get them started. However, we need to also assess them appropriately as well. Now, let's talk about the importance of assessing Crohn's disease activity. There are actually several endoscopic scores that we can use for Crohn's disease. The CDEIS is actually not something that's used in clinical practice because it is time consuming and requires a lot of information. It's considered the gold standard for endoscopic scoring. However, a simpler score called the simple endoscopic score for Crohn's disease is what I use in clinical practice. And it's actually not too cumbersome in that it's probably programmed already in your endoscopy software. Much more easily accessible and reproducible as well. And it looks at presence of ulcers, the ulcerated surface and affected surface, and also looks at narrowings as well. It looks at the ileum, the right colon, transverse, descending, and also rectum as well, and you can mark those specific areas. You can follow that number over time as well. Now, patients who've had surgery for their Crohn's, specifically ileocolonic resection and reanastomosis, we use the Rutgeer scoring that goes from I0 to I4 being the most severe, and it's easy to use, and again can be linked into your software. And the higher the score, that correlates the risk of recurrence of their disease, and you can adjust medical therapy appropriately. Now, why is that important? Well, we actually have studies looking at endoscopic lesions, and the more severe they are, there's an increased risk of colectomy in patients. And this study looked at even at 1 year, there's a 31% risk of colectomy in patients that had severe endoscopic lesions compared to only about 6% who did not have them. And if you move up to 8 years, that percentage doubles to about 62% of these Crohn's patients by 8 years ends up having a colectomy compared to only 18% if they did not have severe endoscopic lesions. So again, important to assess that. And mucosal healing also predicts long-term outcomes, and this study was looked at in using infliximab therapy in Crohn's disease, but other studies have looked at different biologics as well. The patients on the left-hand side here, you see that those that had mucosal healing on the top part of this Kaplan-Meier curve, majority actually remain to be in clinical remission, have sustained clinical benefit from therapy. However, if they're on infliximab therapy and they did not have mucosal healing, during follow-up, patients sooner actually ended up losing response And so it's important to assess that as well. So you can also predict clinical flares based on mucosal healing. And also, if you looked at major abdominal surgery need, patients who had no mucosal healing, significantly higher, almost 40% of these patients had to require some sort of major abdominal surgery for their Crohn's disease, compared to those with even just partial healing or complete mucosal healing. Only about 14% required surgery for their Crohn's. Now, why do we put some significant emphasis on endoscopic findings? Well, it's mainly because we can't necessarily go by what the patients state to us as far as their symptoms are concerned. There's an interesting study. This was published 2 decades ago, but very fascinating study, and I still use this today to teach all my fellows as well, that if you look at patients that describe their symptoms based on Crohn's disease activity index, which is an activity index score, and correlated that to their endoscopic scoring, you see the scatter plot that's all over the place. And we found was that there's absolutely zero, so really 0.13. So no correlation to what the clinical symptoms are to what we find on endoscopy. Now, why is this the case? Well, there could be other causes of symptoms other than active inflammation in Crohn's disease. And these include disease complications such as strictures, fistulas, abscess, complications of surgical resection such as bile salt diarrhea, steatorrhea, small bowel bacterial overgrowth, and also patients with inflammatory bowel disease are not excluded from having irritable bowel syndrome. So they may have symptoms of anxiety or even depression is listed here that could be contributing to their symptoms, but not necessarily having active disease. We all know that having Crohn's disease or ulcerative colitis in general, there's an increased risk of infection, specifically C. difficile infections, sometimes cytomegalovirus infections, and also other bacteria such as E. coli that can contribute. So we need to be sure to appropriately treat our patient and know that if it's not from active Crohn's disease, we don't want to overtreat that where we're ignoring other potential etiologies here. So we need to make sure we treat the underlying etiology at all times. Now, patients may not always want to undergo a colonoscopy every time they need to assess for mucosal healing. So there are other alternative markers. We can use the blood marker set-rate CRP. Not going to talk about it too much because the correlation's better than activity index score, but not the best because it can be elevated in other infections or allergies and colds and so forth. But fecal markers, fecal calprotectin and lactoferrin, are quite useful because they're very specific for the GI tract. Alternatively, you can use radiology, and we'll talk about some of these factors, and also capsule endoscopy as well. So talking about the stool markers, the fecal calprotectin and lactoferrin correlate highly with endoscopic activity. You see in this graph here, in this logarithmic scale, the higher the calprotectin or lactoferrin, we generally see a higher Crohn's disease endoscopic activity score as well. So this is a very useful non-invasive marker of checking stool proteins for inflammation. And this can, we also see that both of these markers can also predict post-operative recurrence after a patient underwent ileocolonic resection. We talked about the red gear score, and you see on the right-hand side that in general, the higher the red gear's endoscopic scoring, generally we see much higher calprotectin scores. We also saw that not only calprotectin at a cutoff of greater than 100 or fecal lactoferrin greater than 3.4 was also associated with specific significant high sensitivity for endoscopic recurrence and also red gear score as well. Now, there's another less commonly used marker called S100 protein, not used in clinical practice, but also correlated as well. So you can use other markers to even predict post-op recurrence. Now, if you look at the whole schema of more imaging and endoscopic evaluation, there are several ways of evaluating them. However, the most common endoscopic evaluation is with ileocolonoscopy. If needed, you can use upper endoscopy, deep enteroscopy, or capsule endoscopy to stage the patient and look at their disease location thoroughly, and we'll talk about those in detail. As far as all of the imaging modalities, CT enterography, MR enterography, and ultrasound is what I'm going to be discussing the most during this presentation. So as far as imaging studies are concerned, abdominal x-rays can be used, but not very useful in evaluating specific details of our Crohn's patients. However, if you have someone who you're concerned about toxic megacolon or bowel obstruction, abdominal x-rays, cheap, simple, and fast to get done in the hospital. And so you can evaluate that pretty quickly. However, it's not going to give you the finer details of what you need for your routine monitoring of a Crohn's patient. Small bowel follow-through has been used in the past, but it's actually a dying modality, I should say, because neuroradiologists are not being trained on this technique because we have neuromodalities such as CT enterography and MR enterography. And although it hasn't picked up speed in the United States, intestinal or bowel ultrasound, which I also do in clinical practice, has been quite useful. And we'll talk about all of these entities as well. So what's the most sensitive and specific to identify active Crohn's? And we'll go into more details of this. If you compare CT enterography and capsule endoscopy, they have great sensitivity in picking up disease. Specificity for capsule endoscopy may not be very high, and we'll talk about why that is in upcoming studies and slides. But ileocolonoscopy gives you the 100% specificity because we are able to get histology when we take biopsies during the procedure. So it's the most important factor here. So this is still our gold standard for identifying active Crohn's in our patients. However, there may be certain patients who don't have colonic disease or upper disease where we can't reach by regular endoscope, and you may need other modalities to look at deep small bowel lesions. So another thing to keep in mind looking at imaging and using CT scans is radiation dose. What we've seen over the years, the number of CT scans has been being used over the decade has increased exponentially. And annual exposure general radiation in the environment is about 3 millisievert, so just keep that in mind. You can compare the different sieverts of radiation. CT scans have the most, about 10 millisieverts per regular CT scan. Now, if you look at Crohn's patients, there are a subset of them that if you look in the study looked at over 15 years of the Crohn's patient, about 15% of them had significant cumulative dose range of over 75 millisieverts. So these patients are high risk of getting cancers in the future. Lymphomas and other solid organ tumors are a major risk. So we want to minimize that radiation. I actually had a very young female, 21-year-old that came to see me, came from a small town where there was no IBD specialist, and she's had significant severe Crohn's disease, and she would end up going to the emergency room every 1 to 2 weeks for her flares. And every time she goes to the emergency room, she ends up getting a CT of the abdomen pelvis. And when I asked her how many times she's had a CT during this past year and a half of her disease flaring up, she told me she had 23 CT scans in the past year and a half. That was more CT scans than she's been alive on this earth as far as years were concerned. So we have to be careful in ordering CT scans, especially for younger patients, because they have the rest of their life to deal with the disease. They go through flares, they go through ERs, they end up getting CT scans over time. So with that matter, I like to use MR enterography as more of my diagnostic and as tool rather than CT enterography. However, you have to be aware of the accuracy of the MR enterography protocol. There was a meta-analysis of 62 studies that looked at accuracy, and it's great for frank disease. For mild disease and those in remission, it was only about 62% accurate. Often MRIs are overstaging disease activity than understaging it, so we have to be careful of finding to make sure you connect that and correlate that to the clinical symptoms and perhaps endoscopic or other imaging if needed as well. It may not be accurate enough to assess for mucosal healing for an ongoing basis unless there's more complications such as strictures or fistulas or abscess. Now, this is where we can discuss how capsule endoscopy may play a role in evaluating for Crohn's disease. You can use it for suspected Crohn's and also in evaluating patients who've already had proven Crohn's disease as well. And in cases where you're suspecting Crohn's and you're not sure, you may need to verify with the balloon or deep enteroscopy to obtain mucosal biopsies, because remember, we cannot get biopsies from capsule endoscopy as of 2020 in clinical practice. Now, in proven Crohn's, capsule endoscopy has more sensitivity compared to radiological imaging and can be used to measure small bowel healing, is less invasive, and there's no radiation involved at all. Now, it does, and we'll talk about the studies that show that it can pick up more proximal lesions, and this is important because proximal lesions can be linked to worsening outcomes such as surgery and higher risk of clinical relapse. So there are some pros and cons to everything that we do, including capsule endoscopy. The pros says non-invasive, allows excellent magnification of small bowel to individual villi, and as a physiological endoscopy, the capsule is moving through passively like you would eat something. The cons is that it's not therapeutic. We cannot do biopsies. It can be time intensive because you have to get the patient to get the testing done all day, bring back the recorder, and then download it, etc. There's a chance of capsule retention, which may require surgery. And of course, if patient has a poor prep, it can reduce visibility of what you're looking at. So that brings up the question of to prep or not to prep. In my practice, based on this study and on my clinical experience as well, I actually do prep our patients. This meta-analysis looked at over 4,000 patients that were on laxatives and 2,000 without. Now, they found there was no improvement in completion rate or diagnostic yield, but improved quality of visualization. And so I typically have my patients take clear liquids until noon the day prior, fast overnight, at least 12 hours, and use typically half dose of a standard bowel prep, or use a large bottle of the polyethylene glycol or magnesium citrate bottle to clear out really their small bowel. I'm not worried about colon prep unless we're talking about the Crohn's capsule, which is a different type of prep, which we'll talk about in just a bit as well. So we're kind of aware of the capsule procedure. The patient needs to be fasting prior and prep, which is what I recommend. And the battery pack and recorder is placed on the patient. The patient swallows a pill and can leave. They can drink 2 hours after the capsule is ingested, and they can eat 4 hours afterwards. And typical recorder is about 8-hour battery life. If you have the 12-hour one, you can have the patient return in 12 hours or the next day. It's important to know that patient does not need to recover the capsule. Patients often ask about this. It's a recorder that gets all the images sent over during the procedure. The capsule is typically just flushed away, and the recorder is downloaded over a few hours, and you can read the capsule when it's ready to go. Now, recommended reading rates depends on what type of view that you're reading here, and you can kind of follow these general guidelines. And if you need more information and get certified, you can actually get certification of capsule endoscopy training through our American College of Gastroenterology website here. There's about 25 cases that you can go through and answer the questions, and you can get certified that way as well if you're interested in that. Now, this is the standard capsule. We'll talk about the Crohn's capsule in just a bit. We're hoping that it will get approved from insurances so we can use it more in clinical practice. And we'll talk about that in more in detail as well. Now, we did start talking about potential cons of using a capsule endoscopy, and there are some technical failures that can happen. The capsule may not activate, downloading may fail, or the battery may not last long enough or fail during the time of the procedure. And you may have an incomplete exam because of this, and it could also be related to prep as well. Now, capsule retention is what we really need to be worried about. It occurs very infrequently, and I've had patients whose capsule, I had one patient, I think it's should go into Guinness Book of World Records, where the patient had their capsule retained for over 6 months or maybe close to a year. He came from a different provider, had transitioned care over to me, and had a capsule done in the past, but it was lost to follow-up and never found out that the capsule had ever left. When I did an imaging, this is when I got a call from the radiologist saying, hey, there is an object in here. Do you not know about it? And this is when we found out much later that he had a capsule that was retained months and months later. He was not having obstructive type symptoms, but that can occur if in certain cases, especially if the capsule is actually retained and blocks the luminal area that's narrowed. So keep that in mind. And knowing that there are specific contraindications, so known or suspected GI obstructions or stricturas, based on the clinical picture or prior testing, it's important you should not do capsule in those patients. Those with cardiac pacemakers or other ultramedical devices that are implanted should not undergo capsule endoscopy. And those that have dysphagia or swallowing disorders, you can get the capsule done if you do it with endoscopic assistant, where you can deploy the capsule into the small intestine. In these patients, you can avoid having them to worry about being unable to swallow, or those patients that have gastroparesis, where you're worried that the capsule may retain in their stomach for hours and hours and not get into their small intestine. Now, there are some relative contraindications listed here, such as surgeries, pregnancy, diverticulosis, and of course, if there's any contraindication, including allergies to bowel prep, if you're using one specific, you can always consider something else as well. Now, we should always document passage. If you had a patient who said, oh, they saw it and they found it in their commode and they had a bowel movement and saw the passage, you're fine. Or if you see that the capsule reaches the colon and they don't have any colon strictures, and they've had a recent colonoscopy, and you know it's going to pass, and you don't need to evaluate anything. However, if you see a capsule, especially if you see the capsule images end in the small intestine, then I would recommend getting an abdominal X-ray within 2 weeks, sooner, of course, depending on availability in the patient, to make sure that that capsule has passed. And if you need to, if you're worried about potential for retention, always use cross-sectional imaging first, or use a patency capsule and make sure you get an X-ray of that patency capsule within 30 hours. Or if you have a scanner for it, you can use that as well. So caution in some high-risk patient. We talked about patients with known strictures with surgeries, but patients that are on chronic NSAID use can also develop strictures in their GI tract. It's patients with suspected tumors that may block or obstruct the capsule passage, or radiation therapy or ischemia where they could develop strictures. Keep in mind to use caution in those patients. You might want to do some sort of other modalities such as imaging or patency before considering a regular capsule endoscopy in them. Now, the age-old patency capsule is actually pretty neat in that it has this lactose body that actually will start disintegrating after 30 hours after ingestion. So this is an example here of a patient whose patency capsule has been retained. So you can get an X-ray about 30 hours after ingestion to see if it's still there. If it is, then if it's still in their small bowel, so if it's in their colon, it's about to come out, maybe in the left side of the colon, you're good to go, not a big deal. But if it's retained in their small bowel somewhere, then you should not do a regular capsule. Often patients don't have any symptoms with it. I did have one patient whose patency capsule caused some pain for a few hours after it got to the site where he had some narrowing, and then once it started dissolving, he became asymptomatic. But we knew in that patient he needed further imaging rather than capsule endoscopy testing. Now, this other concept I want you to be aware of is the capsule endoscopy is not specific. So I have some examples here, not very great examples, but maybe blurry on purpose to show which side of the pill cam, which picture depicts Crohn's disease and which depicts NSAID use. Well, if you can't decipher on this, that's okay. There actually was a study, and I'll explain why, about 40 volunteers that got diclofenac for about 14 days. They did capsule endoscopy and a fecal calprotectin pre and post 2 weeks of the NSAID intake. And what they found was that calprotectin was elevated in 75% of them, and almost 70% had some sort of pathology on capsule, being bleeding, ulceration, erythema. Interesting thing here is lesions were not distinguishable from Crohn's disease. So you cannot diagnose someone with Crohn's, especially if they've been on NSAID. So always ask that history before you get a capsule endoscopy, especially if you're trying to sort out if someone has Crohn's disease or not. They should be avoiding NSAIDs for minimum 2 weeks, if longer if possible, before you consider capsule endoscopy. Now, I want to kind of shift gears to this future of capsule endoscopy, especially in evaluating Crohn's disease. And this is called the PillCam Crohn's capsule. And this is neat in that it can actually visualize the entire luminal GI tract, from esophagus, stomach, small bowel to the colon in a single procedure. And the software is also pretty neat to be able to assess disease activity over time. So with this, the differences from a regular capsule endoscopy is that there's a dual camera, so you'll see a front and back camera, so you can assess which direction the capsule is going, if it's going back and forth, and what's going on behind you, in front of you when you're viewing these. And they also have software, and the report is interesting as well. So you can document the duodenum, the segments, first, second, and third segment of the small intestine, terminal ileum specifically, and the colon areas as well. And you can document the most severe lesion, most common lesion, and the disease extent also. And you can compare different readings over time. So in this case, you're actually comparing your current study to a prior study within the same software. And also you can compare up to 3 separate capsule studies compared over time. So you can kind of follow how they were prior to adjusting therapy, when you started biologic therapy, and how they've been doing over time. So it's pretty neat to be able to do it within the software itself, than to go through all your medical records and try to compare and find their prior reports. So pretty neat here. Now, the bowel prep is actually very different from regular capsule, and this actually involves significant amount of prepping the colon, especially because it's going to take images of the colon as well. So you start clear liquids and you do half of the PEG ingestion, you continue clear liquids afterwards the day prior. Now, the day of the procedure in the AM, they do ingest the additional polyethylene glycol, they ingest the capsule. An hour later, the actual device will signify if the patient's capsule has not gone through the stomach. If it's still in the stomach, it will alert the patient to take 1 tablet of metoclopramide to stimulate the motility and get that capsule to get into a small bowel. If it's already in the small bowel, that alert won't pop up. Now, at alert 1, on small bowel detection, they will actually get an alert to take additional of a small volume bowel prep, and 3 hours later, if it has not left the small bowel, it will signify a second alert to drink additional bowel prep. If they've actually gone through the bowel to the colon, then they don't get the second alert. And then once it gets to the colon, the capsule will signify that if it hasn't left it after this, to take a stool softener bisacodyl to stimulate a suppository to get through the colon. And with this bowel prep, and I've been able to use the Crohn's capsule for several of my patients now, and I've had no issues with getting a beautiful bowel prep and the colon images to go through, and often the capsule is done before the battery runs out, which has been fantastic. Now, let's kind of talk about these modalities and compare that to imaging. Let's talk about score correlation to yield and patient preference. And also, the other thing we need to keep in mind is radiation. Now, MR enterography has been now most commonly used, especially in areas that have the availability and expertise to use it. And there are scores that the radiologists use, the Maria score and the Clermont score, that looks at the degree of small bowel inflammation. We have a Lewis score for capsule endoscopy, and we find is that the correlation of those scores are actually quite nice. It's highly correlated both to MRE and capsule endoscopy scoring. So you can use these as a guide, that if your patient had an MRE in the past, correlate that to capsule endoscopy, or if you had to go back and forth depending on this clinical situation, that you can use those scores to correlate the disease in severity. Okay, let's look at diagnostic yield, comparing Crohn's capsule endoscopy to MR enterography. And they had 47 patients, some with established disease and some with suspected Crohn's disease, all underwent MRE to rule out stricture. And if there was some suspicion, age-old patency capsule was used. And we found was that the diagnostic yield for capsule endoscopy was much higher for more proximal areas. And I brought this up a bit earlier. So to kind of confirm this was confirmed on a study that showed about 32% of jejunal disease was picked up on that same patient compared to only 6% on MRE. Similarly, almost more than half, 57%, of ileal disease proximal ileal disease was found on capsule, only 21% was found on MRE. So the diagnostic yield was much higher using capsule endoscopy compared to MR enterography. So if you look at the overall outcome of the study, the Montreal classifications, what we use to look at location and disease, changed in more than half, 53% of patients based on the capsule endoscopy findings compared to only 13% on the MR enterography findings. So keep that in mind in using the different modalities. There was also a meta-analysis of 13 studies looking at capsule endoscopy comparison to MR enterography and small bowel intestinal contrast ultrasound. I brought this up just briefly that this is, we can use intestinal ultrasound, but this intestinal ultrasound also required a little bit of IV contrast. And this is what their comparisons looked at. So what they found was capsule endoscopy was pretty similar with MR enterography and similar to the contrast ultrasound, detecting and monitoring small bowel Crohn's disease, in evaluating suspected established Crohn's disease, and also with adult and pediatric Crohn's disease as well. However, for proximal small bowel disease, capsule endoscopy was superior to MRE in 7 of the studies, and almost three times higher based on this odds ratio. However, capsule endoscopy was actually similar to contrast ultrasound. So again, keep in mind if you're worried about proximal disease, you may want to use a more sensitive evaluation technique such as capsule or contrast ultrasound if that's available to you to evaluate these patients. And interestingly, there was a look at patient preference and adherence. And what they found, they asked the patients about comparing capsule endoscopy and the MRE. Capsule endoscopy was much better accepted and associated with less discomfort than MRE, even with bowel prep. So with MR enterography, remember, they do have to take a large volume contrast to distend the small bowel to be able to see the wall layers of the small bowel. So that can cause some discomfort. And when they asked the patients which one they would like to do as a follow-up procedure, they more likely to agree to getting a capsule endoscopy done than an MR enterography done. So we talked about different modalities. So keep in mind there are advantages and disadvantages to different techniques. For capsule endoscopy, there's no radiation. We can get great intraluminal evaluation. It's relatively fast, and we can get great proximal small bowel disease evaluation, high sensitivity for that. However, the disadvantage is that capsule retention can occur if you're not careful in who we set up or schedule for the capsule procedure. We cannot evaluate transmural or submucosal disease with capsule compared to other modalities, especially radiological imaging, such as MRE, ultrasound, or CTE. So keep those in mind when you're deciding on which technique to use. Now, this is my diagnostic approach or algorithm that I generally like to use. Of course, in anyone that I'm suspecting inflammatory bowel disease, I always want to distinguish Crohn's from ulcerative colitis. I always look at the terminal ileum, and so that will be my gold standard. However, if it's non-conclusive and you're suspecting still Crohn's disease, then I would recommend getting the capsule endoscopy. Because it will be much more sensitive. Of course, make sure the patient's not on any NSAIDs, or if they were, to avoid it for at least 2 to 3 weeks, ideally a month if possible, before you do the capsule. If that's not beneficial, you need to look for more transmural disease. Consider imaging such as ultrasound, MR enterography, or CTE. If you need biopsies, then consider deep enteroscopy and figure out if it needs to be antegrade or retrograde, depending on the location of the disease based on the capsule or imaging findings. If you have known Crohn's disease patient, they have no obstructive symptoms, then you can also consider capsule endoscopy or consider intestinal ultrasound. However, if that's not available, or if you need to evaluate further, then consider MRE or CTE and deep enteroscopy if needed. However, in your known Crohn's patient that has obstructive symptoms, I would avoid getting them to capsule endoscopy as their first step. Consider imaging first, and if needed, you need to get further evaluation of luminal disease. Considering the AJOP patency capsule first. If it goes through, then you can do the capsule endoscopy. If the patency capsule does not go through and is retained, then you should not do a capsule. You may want to consider deep enteroscopy if you need histological diagnosis. So in summary, Crohn's disease has variable presentation. The treatment plan should be based on the patient's prognostic factors. Symptoms in Crohn's does not accurately depict endoscopic findings, so we need to assess for mucosal healing, and that's what actually predicts or prevents complications, reduces the risk of clinical symptoms, reduces the risk of surgery as well. And you can use other markers besides ileocolonoscopy, even though that's our gold standard, such as laboratory markers and more specifically stool markers as adjunct evaluation, or you can consider capsule endoscopy and different modalities of imaging to monitor patients as well. So as I conclude here, I'll go ahead and turn it over to Lisa, our moderator, and then we can go into any questions that you may have.
Thank you, Dr. Abraham, for that most informative presentation. As the audience is submitting their questions, I would like to go through and tell everyone how you can obtain your CE credit. So continuing education for physicians and nurses can be obtained for this educational activity, and it's been approved for 1 contact hour again. To obtain the credits, you just go to sacsitesting.com/INIT. There you will need to register at the site, complete your evaluation, and then upon successful completion, you'll be able to print your certificate off for completion. Additionally, an archived version, on-demand version, will be available at www.initiative/patientsafety.org. An email will be sent to all registrants when it's available. The on-demand version will be accredited for physicians and nurses as well. Let's look at some of the questions that are coming in. And I have the first question from Sherry. And Sherry's asking, what types of cancers are seen in patients with long history of Crohn's disease and immunosuppressive therapies?
Okay, great question, Sherry. So we do see an increased risk of colon cancer. It's probably the highest cancer risk that we know in patients that have Crohn's disease, especially if they have colonic disease. If they have more small bowel disease, there's a risk of small bowel adenocarcinoma, and these are all adenocarcinomas that we're seeing in our patients. So I didn't go into healthcare maintenance. I was more emphasizing on mucosal healing because that also reduces that risk of colon cancer as well. So for patients that have Crohn's disease, if they've had any amount of colonic disease, I do colon cancer surveillance by colonoscopy after 8 years from diagnosis, and then every 1 to 2 years thereafter to look for any polyps, and if we see any flat lesions, then we need to remove it before it could turn into cancer. If they have small bowel Crohn's disease, we don't unfortunately have any guidelines for evaluating the small bowel annually or every 2 years like we do for the colon part, because the colon cancer risk is much higher than small bowel cancer in Crohn's disease. However, I have had my share of patients who've had small bowel cancers from their Crohn's, often is with long-standing disease, not 8 to 10 years, but more like 20, 30 years of diagnosis. Now, for those patients, because we don't have any specific guidelines, I do recommend some type of monitoring for them. If they have ileal disease, that's terminal ileal disease, and we can always evaluate that on colonoscopy going into their terminal ileum. However, if they have more proximal disease, this is where the capsule endoscopy can be useful to confirm there's mucosal healing. And also, you can also consider imaging such as ultrasound, MRE, or CTE. However, we don't want to be doing CT scans every 1 to 2 years for these patients if we can avoid it. And MREs can be expensive as well. So you can consider maybe capsule endoscopy, or if available, ultrasound to assess for any abnormality in their small bowel. And immunosuppressive therapies, I think patients are really concerned that biologic therapies, immunosuppressive therapies, increases their risk of cancer. To answer that, sure, it can, is on the label, so we always need to discuss that risk-benefit ratio. However, what we've seen is the benefit of treating the patient with immunosuppressive therapies far outweighs the potential risk of cancers that may be linked to them. We're seeing way more colon cancers with untreated Crohn's than we are seeing lymphomas or any other solid organ tumors with immunosuppressive therapy. So keep that in mind, that risk-benefit balance needs to be in place, and have that candid discussion with the patient. Now, patients are worried about it. So specifically, I do tell them that in general, with longstanding disease, we rule out, the main thing is to make sure they don't end up getting colon cancer. On the other hand, if they're worried about the other cancer risks listed on the label for all these medical therapies, I explained that the relative risk is actually extremely the absolute risk and the relative actually is extremely low. However, there are specific things that we need to take in mind. So if they're on immunomodulators such as azathioprine, 6-MP, 6-mercaptopurine, or methotrexate, there is an increased risk of non-melanoma skin cancers. Such as squamous cell and basal cell. If there's family history, or if there have been sun worshipers in their childhood and they're older, these are the increased risk. So typically, all of our patients need to be seen annually by dermatologists anyway, just for skin checks routinely. If they are on these therapies, and I make sure that they are very compliant with that, if there's any family history, or if they've had prior non-melanoma skin cancer, they need to be seen more aggressively, like every 6 months or sooner if needed, based on what the dermatologist says. There's also increased risk of actually regarding skin cancers, for biologic therapy, specifically anti-TNF therapies, there is a slightly increased risk of melanoma skin cancers, not the other skin cancers. So if there's a family history of melanoma, or if a patient previously had melanoma, then I do not recommend anti-TNF therapies, because we have other options as other biologic therapies, so keep that in mind as well. Other solid organ type tumors, we haven't seen significantly in biologic use. There is more of an increased risk of lymphoma with immunomodulator therapy. So if I have an elderly patient, I try to minimize or avoid azathioprine, 6-MP, and those type of medications to reduce that lymphoma risk as well. So it's all a matter of risk benefits, but overall, the colon cancer risk is the biggest concern that we have in Crohn's patients.
Thank you. We have another question from Shannon, and she's asking, for pediatric patients diagnosed due to fistulizing Crohn's, any special considerations for monitoring beyond presentation?
Okay, so the question is regarding pediatric onset fistulizing Crohn's disease. So just hearing that means they have two major risk factors, right? So pediatric onset, we mentioned less than age 40 is an increasing higher risk factor, and fistulizing disease already a high risk factor. So for those patients, they need to be monitored very closely, and they need to be treated appropriately and aggressively early on as well. Now, having said that, how do we monitor them? Well, it also depends on where the fistula is. So if it's perianal, then it's easier to monitor, and this is where we would, from a GI or gastroenterology perspective, as providers, we can follow them just how they are clinically in clinic, but those patients also need to be closely monitored by colorectal surgeons as well. Often they may need setons placed in the fistula, they may need repair, do fistulotomies, etc. So I work closely with the colorectal surgeons to monitor how their fistula, especially perianal disease, is doing. Now, on the other hand, if you have someone with fistulizing disease that is enteric or enterocutaneous, meaning going from small bowel to other small bowel, or enterocolonic, going from small bowel to colon, or in some cases where you can have from intestine to other organs like to the vaginal area or the bladder, then those patients also need to be aggressively treated. They start biologic therapy right away, and they also need to be followed closely by the surgeons, typically the colorectal surgeon, and often you may need to be working with a urologist or an OB/GYN, depending on which other organ is involved. And for those patients, we aggressively treat them with medical therapy, but often they may also need to be treated with surgical management as well. And how do we monitor them afterwards? Well, it depends on the locations. They have a high enteroenteric fistula, and they don't have a stricture to that. You can follow them with capsule endoscopy or imaging such as MR or CT enterography. My preference is MR enterography because pediatric onset, again, try to minimize that CT scan use if at all possible, and follow how they're not just their luminal disease, but structurally what's going on. In some of these cases, you may need to do upper endoscopy, consider capsule, and also imaging, and use all 2 or 3 different modalities to monitor them from both from the luminal aspect and also from the structural aspect outside the lumen, because patients like those may end up having lots of scarring, strictures, and issues with bowel obstructions as well, especially if they've not been aggressively treated early on. So really, again, to answer that question, depends on their location of their fistulizing disease, but key here is treat aggressively, work with the multidisciplinary team, often with the colorectal surgeons, and monitor them based on their location of their disease, either by clinical exam on the perianal area, imaging such as MRI of the pelvis, or upper endoscopy, enteroscopy, capsule. They have enteroenteric or enterocolonic or other organ fistulas as well.
We have another question, Dr. Abraham, and this is probably going to be our last one.
Okay.
2 minutes left. This is from Doug, and Doug's asking is there any role for altering gut microbiome with the use of antibiotics, probiotics, or fecal transplantation in managing IBD symptoms?
Okay, Doug, great question. Well, there's a lot of things that you want to discuss. So antibiotics, probiotics, and fecal transplant. So let's talk about all the 3 separately. So antibiotics have been used actually very commonly in patients. There's not great data of using antibiotics in treating the disease specifically as far as active inflammation, but specifically in Crohn's disease, especially if they have perianal disease, perianal abscess, perianal fistulas. I am a big fan of using ciprofloxacin and in combination or alone with metronidazole, because both of those antibiotics, and specifically there's more data with ciprofloxacin in reducing inflammation, helping with perianal disease. However, it should be used as adjunct therapy, not as a standalone therapy for those patients. But we don't have great data that antibiotics necessarily helps with Crohn's disease in general, especially with luminal disease overall. Even though I see that being used, patient gets admitted to the ER, or the hospital ward, and then the ER physician or the primary hospitals may put them on antibiotics thinking, oh, they have a Crohn's flare, let's see if that can calm down the gut. It typically does not do anything. So I don't necessarily recommend using that. Now, on the other hand, I did mention some other causes of symptoms of Crohn's patients, and one common one is actually small intestinal bacterial overgrowth. And this is where patients can get, it often can happen in patients who've had prior surgeries, or they have some sort of narrowing or stricture, where maybe they're not completely stenosed, but flow of content through their intestine is slower because of that narrowing. And what happens is the bacteria actually builds up, and you get small intestinal bacterial overgrowth. That can cause symptoms such as gas, excess bloating, or even diarrhea as well. And in those cases, yes, you can use antibiotics for those patients because that will reduce that bacterial burden, and then reduces the bloating, and maybe it also can reduce diarrhea from that. So that can be useful in that specific case. And there's been different types of antibiotics that's been used in study. I mean, those not specifically FDA approved for any specific bacterial overgrowth per se, but used medicines such as rifaximin to amoxicillin to any antibiotic that can work on the gut microbiome, reduce that. So that can be useful there. Now, probiotics. So often patients take this thinking, oh, it's great for gut health, let me go ahead and take it. However, there was actually no evidence to signify that using probiotics in Crohn's disease is beneficial. The best data that we have is in patients who've had colectomy and have a J pouch or ileal pouch anal anastomosis, where patients can develop what we call pouchitis or inflammation of that J pouch. And probiotics have been studied and been shown to be effective in treating symptoms of it, or if they've been treated with antibiotics for that J pouch inflammation, you can use probiotics to prevent recurrence as well. So that's really the main area to use probiotics. Other than that, it's not going to help for their intestinal luminal inflammation, no benefit in visualizing disease or stricturing disease. So I tell my patients, don't waste their money on it. Now they can eat yogurt for general, yogurt's good for you in general. If they can tolerate it and they like it, then you can eat that for general, benefit, but no, don't waste money on getting probiotics over the counter or additional. Now, fecal transplant. So that interesting topic, there's been several studies looking at it. The early studies that were non-randomized suggested, it could actually help with treating inflammatory bowel disease. However, when the randomized control trial started, we found actually no benefit. Now, there was a very interesting study that did show some benefit, but when they deciphered and looked into the details of the patients, again, these were small number studies, what they found was there were a subset of patients who did improve with the fecal transplant and a subset that did not. When they looked back at the subset that actually did improve with fecal transplant, they all traced it back to one single fecal donor. So that donor was essentially laying the golden poop here, and that donor's microbiome, for whatever reason, did help those patients. However, another donor, and that, remember, all those donors were vetted, no IBD, no Crohn's, no colitis, no GI symptoms, and all that. Even the other donor who was asymptomatic did not help those patients that received their stool. So there's something yet to be learned from the gut microbiome. We know that fecal transplant works fantastically for C. difficile infection, but we haven't found fantastic evidence like that in inflammatory bowel disease. So there are still clinical trials ongoing with that, but no great data as of yet where it's not been FDA approved for clinical practice. And patients ask me this all the time. So I tell them, look, it's something they can consider for a clinical trial protocol at a center that's doing it. However, all the patients that I've had undergo fecal transplant for their IBD, and they've had C. diff, and they got the transplant approved from their C. diff indication, their C. diff improved, but their IBD still remained severe, and they ended up needing additional medical therapy, or some ended up having colectomy or additional treatments of C. diff when their C. diff recurred later because their IBD was not under control. So that's what we have.
Thank you. That is going to conclude our question segment. And Tracy, I'll turn the program back to you.
Thank you. We'd like to thank everyone for attending today's webinar, and we wish everyone a pleasant rest of their day. Thank you.
Thanks.